Good morning, everyone. My name is Mr. Rodney Dipple. This is my partner, Sergeant First Class Gaston Garcia, and we are instructors with the United States Army School of Aviation Medicine. This morning, we're here to discuss with you patient packaging. Just imagine your first medevac deployment, your first 9-line, your first mission, and it's a critical care transfer. There are many acronyms that you can use to help you to accomplish this mission. One technique or one acronym that we're going to use is HABCI. HABCI is intended to help you break down the patient packaging in a step-by-step process to enable you to accomplish your mission with success. Let's start with H. H stands for hemorrhage. So some of the things we want to look for when it comes to hemorrhage is obviously we want to look for bleeding. Now this patient is not a point of injury patient. You should not walk into your FST, your PACU, your ER, and find a patient with bright arterial spurting blood. However, you are going to find a patient who has multiple injuries, who has already received some type of treatment or damage control resuscitation. So some things that we want to do is we want to start looking for and assessing for hemorrhage. We're going to do that by starting at the head. We're going to look at all dressings, look at all areas of possible concern, and if we find any bleeding, what we want to do is we want to take a Sharpie or some type of marker, and what we want to come around it and just mark that bandage to outline the portion where the patient has been bleeding. This way, if we have a continuation of bleed or more bleeding started in flight, we can see the growth or the development of that hemorrhage, and we can apply more bandages or the relevant treatment. All right. So as we're going through and we're looking for bleeding and we're finding areas of concern, we're marking them. Coming down, looking at the chest, obviously no injuries. The belly, obviously this patient does not have an exploratory laparotomy or blood bag, so we're not going to worry about that at this time. Looking at other dressings areas, making sure that there's no bleeding or concerns for bleeding there. Coming down all extremities, front and back, just looking for areas of concern. All right. After we've checked the front of the patient, it's very important that we check the back of the patient. All right. As we get ready to check the back of the patient, our patient does have an airway, so we want to make sure that someone's at the head holding the C-spine, but most importantly, maintaining positive control of the airway. All right. Then you're going to have someone log roll the patient on the most appropriate non-injured side. All right, on the headman's count.
1, 2, 3, roll.
And we're just going to sweep the back, looking for any other possible areas of bleeding. Make sure we check the rectum, underneath any bandages that we could not see, underneath the other extremities. All right, on the headman's count.
1, 2, 3, down.
After we are sure that the patient has no other areas of concern for bleeding, exit wounds, puncture wounds, anything of that concern, we can move on to possible bleeding concerns in flight. Now, what does that mean? Well, we've checked all the injuries, but now are there other possible places or other concerns that we should have during our transport? And there is most definitely. Just like Murphy's Law, whenever you're working on one thing in an aircraft, you're most likely going to pull out something using your ALSI gear or maybe your scissors in your pants, or however you have your kit set up, you're going to pull stuff out. The A-line is one of the most prominent things that can sometimes be dislodged or pulled out during flight. So what we like to do, and this is a technique, all right, is identify where the A-line is, take a tourniquet, prophylactically, place the tourniquet above the A-line, we're not going to tighten it down. This is just snug to the skin. So if for whatever reason you lose your A-line in flight, all you have to do is twist and tighten, and that should control the bleeding. If you've had the advanced evasive monitoring class, you know that the most appropriate corrective action is elevate the extremity, DPO, direct pressure, and observe for 3 to 5 minutes. Well, you may not have time to do that in flight, so this is a quick tip or trick to help you if you're dealing with multiple situations at one time. Other things that you can do if you're worried about extremity injuries, maybe you have an amputation or multiple amputations, or if you have an entrance or exit wounds in the extremities, you can place tourniquets where those injuries are as well. Now this patient has an external fixation device, and most likely it will not bleed in flight because it's already been surgically repaired. But if it was an amputation, like I said, or something like that, and you were worried about it bleeding or to start rebleeding in the aircraft, then you would want to place prophylactic tourniquets there as well. And again, you're not tightening them down. You're just tightening that. You're just getting them snug. So then in the event the patient starts to bleed again in flight, all you have to do is secure that tourniquet. There's another area of concern when it comes to hemorrhage that may not be as noticeable and most people don't think about, and that's the belly. Currently, the patient has to have no signs of internal bleeding, but internal bleeding can begin slow, and at altitude it can extenuate faster, or vibration of the helicopter can cause maybe a small laceration to start to extenuate even faster. So what we're going to do is we're going to measure the belly and we're going to get a baseline. There are two reasons why the belly can distend in flight. One is gastric distension. Two is hemorrhage. So we're going to take some tape, put it on that side, and I'm going to show you on this side. And we're just going to use a quick reference marker. All right. And this is going to become our baseline. The other thing that we're going to do is we're going to grab any type of tubing that we have, oxygen hose, NG-OG tube, extra IV tubing, cut to size, whatever you want to do. And we're going to mark it or flag it using this tape. And we're going to set it up here, getting it on our baseline marker. We're going to run this hose across the belly, and we're going to identify the other spot that we put on this side, and we're going to line them up. Now, this right here gives us our baseline abdominal measurement, okay? In the event that we have gastric distension or maybe hemorrhage in flight, all right, our markers will not line up because we have distension. If that happens, it's our job to identify, is that from hemorrhage or is that from gastric distension? And we can do that by assessing vital signs and other things, signs and symptoms of shock. It's very important to maintain this tool that you have either with the patient or on your persons so that you know where it is at all times. That becomes your standard. Finally, for H, since our patient is receiving blood, we want to try and either see if the patient has been cross-matched and typed for blood, or if not, if they're getting O negative or AB plasma, we want to ensure that we get the appropriate blood for them and see if we can get any additional units from the facility to take with us as required. Now that we've covered H for hemorrhage, we're going to look at A for airway. When looking at the airway, you simply just want to check for security. Most importantly, ensure that the airway is secure. You're going to look at position. You're going to look at the depth. So let's see, we are in a 7.0 ET tube, 24 at the teeth. We're going to ensure that our ET tube holder is in place, that it's properly securing the ET tube. We're going to flag it. And what I mean by flag is we're going to take this tape and we're going to place it up here like this. And it's going to wave like a flag in the sky. All right. In the aircraft, we're not going to be able to check the numbers on the tube as easily as we can in the environment that we're currently in. So by placing the flag up here, it gives us a symbol of if our ET tube is still in the appropriate spot. If it is way up high, flagging in the air, we know that we possibly have a dislodgement. If it is pushed down too far past the ET tube holder, we know that maybe we have right main stemmed. So this is a good indicator and a quick reference for evaluation of the position of our tube. All right. So after we've checked for position and security, something else that we can do is we can add a C-collar at this time. Now I know that the patient's C-spine has already been x-rayed and cleared, but we're going to use the C-collar as a tool for airway security. We're going to place the C-collar, and what this does is it provides us a little bit of extra airway support, right? In the aircraft, the patient's head's gonna vibrate a lot, right? They probably have muscular blockade on, they're paralyzed, so they're not gonna have the ability to support themselves as much as they usually can. So by placing the C-collar, it will help limit that head bob. After placing the C-collar, we can move on to the ET tube cuff, all right? So what we wanna do is the ET tube cuff, we wanna ensure that we check for pressure. Now, if you have the appropriate tool to check or measure pressure, that is the recommended guideline. If you do not, then a technique is you can take a 10 cc syringe, you can back out all of the air out of the cuff. You're going to get a low pressure alarm, all right? And then what you're going to do is you're just going to slowly inflate air back into the cuff until your low pressure alarm goes away, ensuring that you have just enough air in there to maintain a positive seal in that airway. Sometimes these ET tube cuffs can be overinflated, and as you climb up in altitude, that can cause problems for you in flight. This is just a good technique. All right. The next thing we can do is we're going to check and make sure that we have an NG-OG tube in place. It is recommended that all patients who are transported via rotary wing or have a NG or OG tube in place. If not one in place, then we will place one. This patient does. So what we're going to do is we're going to ensure that it is open. And then another technique that we're going to do is we're going to grab some type of 60 cc or 50 cc syringe, Toomey syringe, something like that. We're going to take some 4x4s. We're going to place inside of our Toomey syringe, all right? And then we're going to cap it on the end of the NG-OG tube. Now what this does is it still allows gas to escape the belly to help with gastric distension, but also if we have any fluids, blood, vomitus, or anything like that coming up out of the belly, we'll be able to see color change in our 4x4 and let us know that we may have a problem. So again, that's just a good technique or good tool. The other thing that we need to do with our NG-OG is we need to check it for position, documentation, and security. So we're going to look at it. We're going to look at the numbers. All right. It's also recommended that you document the numbers and then flag it as well. All right. And this will let you know if it has gone in too deep or if it has started to come out too far and not becoming effective. All right. And then finally, what you can do is you can secure your NG-OG. And a technique to do that is you can secure it to your ET tube. You can secure it to your ET tube cuff holder, your ET holder. And that's a good technique, but I don't like to necessarily put it around the tube. I don't want anything pulling on my airway as much as possible. So if I put it around the cuff holder, the ET tube holder, I know that it's still going to stay in place. All right. Finally, last thing we want to do is we want to check the chest x-ray. All right. We know that we have good end-tidal CO2. We know that we have proper placement depth. We've secured it. Just verification via chest x-ray is the most definitive way to confirm airway placement. Now that we've talked about H for hemorrhage and A for airway, we're going to discuss B for breathing. This is a great opportunity for you to take the time to do a true assessment of your patient's breathing. In the aircraft, you're not going to have the ability to use tools like a stethoscope. So now what we're going to do is my partner is going to check lung compliance, and I'm going to take an opportunity to oscillate breath sounds. We're going to remove the patient from the vent. My partner is going to bag the patient on oxygen. I'm going to check apex to apex, base to base, ensuring that I have good breath sounds in 4 quadrants. After that's done, I'm going to lay my stethoscope down. And I'm going to check chest rise and fall with my hands. My hands now become my new diagnostic tools in the aircraft. I do not have the ability to oscillate, but I do have the ability to feel and observe. So take your hands, get them up on the patient's chest, feel that chest rise and fall, look for equality with every breath, and this now becomes your baseline. After I have done that, my partner and I are going to swap. I'm going to take over bagging for the patient. And what I'm doing is I'm checking baseline lung compliance. This BVM right here should always feel the same every time I bag the patient. If it gets taut, I know that I may have an obstruction. In the aircraft, it's very common for you to second guess yourself. If two people know what right feels like, then you're more likely or more or less likely to make an error in judgment. After we have both completed our assessment of breathing, we're going to place the patient back on the vent. The patient is back on the vent. Now, a great place to put this tool, the same one you use, the same one that you tested with, is underneath the patient's head. It provides a little bit of inline stabilization, and the guy, whoever's handling your airway, will always know where the BVM is, okay? Something else you can do is you could take the pocket mask. For whatever reason, if your patient's airway becomes dislodged, we didn't stay behind our medication, and he rips out his ET tube, whatever like that, we need to bag the patient. If you don't have this handy or nearby, you're going to be scrounging through the aircraft looking for your pocket mask. So a good tip or trick technique is to place it on the exhalation port, right, so that it's always at the head of the patient as well. Okay. So we've checked for compliance. We've auscultated our heart and lung sounds. All right. Now's a good time to request an ABG. If you haven't already requested an ABG, you can look at the previous ABG, but we're about to put them on the vent. We want to know if the ventilation has been working appropriately. All right. We're going to calculate our vent settings. We're going to look at what the hospital has them on. Say this patient is on a tidal volume of 490, respirations of 16, FiO2 at 80%. We're going to make sure that the respirations meet the vent settings, meet the needs of the patient. If something seems off, if something doesn't feel right, please feel free to talk to your doc and say, hey, why was the vent settings at this or that, before you make any crazy adjustments to your ventilator. Most commonly, the hospital is going to have them on the appropriate vent settings, but it's really good for you to double check. As we get ready to start setting them up on the vent, some things that you want to consider. The CCAT CPG recommends that all ventilatory patients during transport will be elevated their head of bed 30 degrees. So we want to make sure that we elevate their head of bed 30 degrees for transport. And also while we're setting them up on the vent, we want to use the hospital's O2 as long as possible. We only have a limited supply of O2 bottles in our aircraft, and we're going to be here for another 10, 15, maybe 20 minutes. And so as we're here for a longer period of time, we don't want to use one of our bottles before we even get into the aircraft. So keep your patient on hospital oxygen as long as you can while putting the patient on your vent. We're going to start setting the patient up on the vent. Now that we have completed setting our patient up on the ventilator, I want you to note that we have taken some padding right here, placed it between the patient's legs, placed our oxygen bottle down here, pre-staged with our oxygen hose connected, ready for placement on our ventilator, and our patient is venting well. Now that we've completed ventilatory management and setup, I want to talk about C for circulation. What we want to do with circulation is it's a great opportunity to check CCT and peripheral and distal pulses. So we're going to check our skin color condition and temperature. We're going to check our distal pulses, making sure that they match what our current vital signs are telling us. Check our peripheral pulses, making sure that we can find them, and you can even mark them on the patient if you need to help you identify them in the aircraft during flight. After we validated all of our pulses, we want to ensure that we have two sites for venous access. You can have a central line or a peripheral line, 2 peripheral lines, whatever you have, but the SMOG requires 2 access points for transport. If you don't have 2 access points, now would be a good time to get a second one established instead of having to do that in the aircraft. Once you identify your 2 ports, you want to go ahead and flush those lines. Just take a normal saline flush. If you have blood running or anything like that, you don't need to disconnect the blood to flush it. You know that it's running if it's got something currently in there. Anything that doesn't have anything running, go ahead and flush those ports to make sure that they're not clotted off. If they are clotted off, it's a good opportunity to go ahead and pull that, DC that line and start a fresh line. Also, what you can do is you can mark your lines. It's important to note what your plan is in flight. So we may have to give medications. If I have IV bags hanging, maybe drips or whatever, I can annotate what's on each line at each port. Or if I choose to use my central line here as a medication port, I can simply flag it and write M1 on it. M1 lets me know that this will be my first and primary choice for medication, or maybe my peripheral line, maybe I will flag that as M2 to let me know that that'll be my secondary port, or however you want to do it. But once you get all of the stuff on top of the patient and you get into the aircraft, you want to have very easable identification marks to help you find what you're looking for. Now, we're going to have to set up our monitor, do our circulation, and start zeroing our invasive lines. So we're going to grab a litter strap and a blanket. I'm going to come down to the feet of the litter. Getting the litter strap on there, make sure you want to get it nice and tight because this is going to be your table. Okay? Take your blanket, set it on top of your litter strap. Use your patient's heels if you can, or their feet, depending on how long they are, all right, to make that platform for you. Now what this does, it gives you a nice tabletop so that you can put any other additional equipment on there that you may need. So we're going to grab our Zoll ProPack MD, whatever you have, and start hooking up our patient to our monitors. Now this is where it becomes very important for you to keep everything in neat, as clean as possible. You can see we've already got vent hose running up there. We've got IV fluids running. We've got blood running. We've already got a whole bunch of other wires going up there. So it's extremely important that you try to keep everything as segregated and as neat and clean as possible. So I'm going to pull out one piece at a time. This is just a technique. All right. And I'm going to run it down one side of the patient. My partner is going to start hooking everything up that we're putting on and replacing it with what the hospital has on there. So we're going to remove the hospital stuff and we're going to replace it with our stuff. As he's getting that hooked up, I'm keeping it neat down the side. And then anything not being used, I'm putting back in the bag. I'm also going to ensure that we're getting our entitle hooked up. Pulse ox. And again, removing all the hospital stuff, getting all of their lines and everything clear, and getting ours hooked in there good. Anything, all the excess line not being utilized is being placed back in the bag as to not get tangled. At this time, you could take some tape. You can even tape up your lines if you wanted to help keep them together. Just a little tape. Right. Keeping them nice and clean so that they don't start getting all jumbled up. Okay. If your patient has a blood pressure cuff that is compatible with your monitor and the facility doesn't mind exchanging, you can just exchange cuffs with them, hook up the cables, give them your cuff, you get their cuff, and then take your extra blood pressure cuff cable and put it back in the monitor bag as well. The more you can put back in the bag, the better off you'll be. The easier your patient will be to manage. All right. Now we've got our patient hooked up on our monitor. We've got the end-tidal on. So I'm going to come here. I'm going to hit the CO2 button. And what that's going to do is it's going to initialize and zero my end-tidal for me. Now we also have to zero our invasive line. So I'm going to pull out my pressure cable. I'm going to ensure that I'm in whatever pressure I'm in. I'm in P1. All right, look at all this excess cable. So we're going to put as much back in the bag as possible when we can. We're going to take them off their A-line monitoring. As soon as I plug them in, I'm going to get, my monitor is going to identify that I've hooked up to a pressure line. So I'm going to hit IBP, P1. Now before I zero, I'm going to close it off to the patient, open it to atmosphere. I'm going to hit 0. It says zeroing. Once it's zeroed, and close it off and open it back up to the patient, and I'm getting a correct reading so I know that my pressure line is zeroed. Take all of this excess cable, put it back in the bag. Now if you wanted to go ahead and put all this stuff with your other cables, you can do that as well. All right. That way everything is down and connected with the patient. All right. So we've assessed our distal pulses. We've checked CCT. We've ensured we have 2 points of access. We've flushed our lines. We've zeroed all of our lines. We need to make sure that all of our IV bags or blood bags or on pressure bags, they don't have to be at pressure for your flight. Fluids do run through gravity, and if they're on a pump, obviously they'll run off the pump. But it is good to have them on a pressure bag just in the event you need to give a little bit more fluid in flight. And it's also a little easier to hang them that way and keep them all together. We're going to make sure that all the air is out of the bags, and then we're going to take them and we're going to put them at the position and where they're located. This is one of my favorite techniques because most commonly what I've seen, especially with students coming through the schoolhouse or some other providers, is they just take the bags and they just put them on the chest like this. Right? Well, they're on pressure, they're going to run. That's correct. If they're on pressure, they will run. But a lot of times now, as soon as you look at all these cables, you throw them on there, they get all tangled. So what I like to do is make sure the pressure's on. I will wind them up and I will put them at the port in which they're located. This gives me easy access, so I know that my blood is at the central line right there. If I had a peripheral line, I would wind it up and I would put it here at my right-sided AC, and my A line is going to be wound up and put right here inside at the A line. Okay, this lets me know, so as soon as I get into the aircraft, I can just pick them up and hang them above the patient. Okay. Also a good time to go ahead and review your CBC and your Chem 7 and ensure that you're tracking the amount of fluid your patient has received versus the amount of fluid out your patient has put out. So measuring ins and outs is very important at this time. All right. While you're measuring ins and outs, you can go ahead and look at the Foley, drain the Foley or have the nurse drain the Foley, and then we'll get that on top of the patient right before we wrap them back up. We have just completed C for circulation, and now it's time to look at I for interventions. First thing you want to do is you want to get a good neuro assessment. Check for PERLA, ICP considerations, looking for signs and symptoms of a head injury. After you've done that, we also want to see, is it time for sedation? What type of sedation meds have my patient been receiving? Do I need to draw a set of sedation meds for his next dose? It is highly recommended that before you leave the facility, that you sedate your patient with the appropriate meds for that loading time, okay? You want to ensure that you have your patient sedated prior to loading them into the aircraft. After you've dealt with the sedation, the organization and access of your medications, and ensured that your patient is sedated for transport, make sure that you place eye and ear protection. For the eye and ear protection, remember your patient needs to be protected just like you protect yourself, all right? So if your patient has a head wrap, that should suffice for eye injuries, but make sure we have good hearing protection for our patient. When you're going through all this and you and your partner, you need to think about differential diagnosis. Now is a great opportunity before you wrap up your patient and move them to the aircraft is to consider what things could go wrong with your patient. Talk to your partner. What are your concerns? What parameters are we going to look for? Discuss with the doc. any concerns that he or she may have that you may encounter during flight. If your patient is on 90% FiO2 and you know that you have a long transport time and only 3 or 4 bottles, maybe you can consider dropping your FiO2 down to 60%. Ask the doc, what SpO2 would you like the patient to remain at during the duration of your flight? If your patient has a head injury, maybe you need to consider a good baseline MAP. The SMOG says the MAP should be greater than 80 or systolic blood pressure higher than 110. So maybe you want to shoot for a MAP of 85. All right, so just talk to the doc and see what things that he or she may want you to consider in flight. And if those things don't happen, what are going to be your interventions? If my MAP drops below 85, what is our first course of action? It's a good time to do your differential diagnosis. Patient loading. We're about to load this patient up. For the purpose of simulation, we do not keep the patient covered at all times, but just note that during your packaging, you would keep your patient covered, keep them warm. Treating for hypothermia is a very serious thing. It is part of your triad of death, and you want to make sure that you keep your patient warm at all times. Before you load your patient, don't forget you have to swap back over to your O2. During this time when we've had our patient on the vent, we've had the patient running off the hospital's O2 to conserve our oxygen. So we're going to go ahead and make that transition now because we're getting ready to wrap them, make sure they're all bundled up and ready to go. So we're going to swap over to our oxygen, and this starts our clock for oxygen. Typically, with the D-size cylinder, on a ventilated patient, based on pressure and FiO2, we estimate 20 minutes of oxygen, but that's going to change based on your FiO2, how much pressure is already in your tank. So just ensure that you're monitoring your PSI closely. All right, we've got them hooked up to our oxygen. We're going to get them covered up and warm. We're going to simulate that now. And then we're going to strap everything down using our litter straps. We talked about the Foley earlier in the video. Now would be a good time to just go ahead and tuck that in underneath here. We've already measured the ins and outs during C for circulation. If you put the litter straps over the vent on his legs, it's kind of like a twofold thing. You're getting the equipment secured and you're also securing the patient to the litter. Place a litter strap above on the chest. And then also don't forget to strap down your monitor on the bottom. You don't want this to fall off during transport either. You need to make sure that all of your equipment and your patient is secure. Before you move to the aircraft, think about your airframe, think about your configuration. Are we going to load head first, feet first? Think about how are we going to treat this patient in flight. Make sure you have those considerations in mind before you get out to the aircraft and have to do multiple shifts. That concludes today's block of instruction on patient packaging.